Hi, I'm Dr. Mark Skeen, Associate Professor of Neurology at Duke University Medical Center. This is another of a series of videos to discuss various aspects of multiple sclerosis. Hopefully that'll be informative to you. So what I'd like to address during this video is that multiple sclerosis for most individuals is a relapsing disease. We talk about relapsing and remitting multiple sclerosis. I want to talk a little bit more about what a relapse is and what it's not, why it's important, what we do about it, etc. So I tell my patients that a typical relapse of multiple sclerosis is some new neurologic symptom that they may never have experienced before, and it often comes on over a day or two. It can be more sudden than that, but it tends to be over a day or two, and then it gets better over weeks or months. And that's true whether we treat the relapse or not. So the relapses on their own tend to remit, if that makes sense. And so that's typical. So it's usually a new symptom that they've not had before. Why? Well, it's unusual that multiple sclerosis keeps coming back in the same place in the brain or the spinal cord. And it is the location of the inflammation which causes the symptoms. So if I develop an MS plaque over here in the left side of my brain, right underneath the cortex, then depending on whether it's up front or in the back, I may have weakness or numbness, for instance, in my right hand. So the same would be true if I had a stroke there, or if I had a brain tumor there. I might have weakness or numbness in my right hand. The location determines the symptoms, not the disease process. All of the disease processes cause similar symptoms. The challenge often in MS is to understand whether the symptoms a person is experiencing at this moment are a relapse or not. So most patients with MS will tell you that they have good days and bad days. And on a bad day, they may feel their old symptoms again. And on a good day, they don't. So because old damage in the brain or spinal cord can be felt at a later time, it's possible that symptoms recur, the same symptoms we've had before in particular, can recur even if there's no new inflammation or damage from multiple sclerosis. This is a big challenge for physicians and patients because patients appreciate the recurrence of their symptoms. And often the physicians are most concerned about, is the disease active again? The reason is, if the disease is active again, if there's new inflammation, we may need to treat that inflammation. And although we haven't talked about treatments yet, signs of ongoing or new inflammation may tell us that we need to change the therapy that people are on long term, the therapies that tend to slow down the disease, what we call disease modifying therapies. So anytime we see disease activity, we may need to change the therapy. On the other hand, new symptoms aren't always the result of new disease activity. And so it's often a challenge for doctors and patients to separate those things, and that's part of what I wanted to talk about today. So not all symptoms of multiple sclerosis are signs of a relapse, particularly symptoms that you had before. If you get an infection, a urinary tract infection, or the flu, or you're having a particularly stressful day, or you have some other illness, or whatever, maybe you've overexerted yourself. For many reasons, those old symptoms can occur again. You can feel the result of that old damage in the brain or the spinal cord. And that may not have anything to do with whether your multiple sclerosis is active at this moment or not. The symptoms are present, but the disease may not be active. So how do we tell the difference? Well, we cannot always tell, just to be honest. But there are some things that suggest whether something is a relapse or just other symptoms of old damage. The first is, if it's a new symptom you've not felt before, or it's on a different side. Maybe you had left arm trouble before, and now you have new right arm trouble. It's much more likely that new symptoms that are different than previous symptoms would be related to a relapse. but again, not always. The other thing is that a different time course. If something comes and goes in the course of a day or 24 hours, it's very unlikely to be a relapse. Relapses just don't come and go that fast. So symptoms that you have today that are gone tomorrow usually are not a sign of a multiple sclerosis relapse. Symptoms that occur in the setting of fever, like from another illness or something, are very commonly the result of old damage rather than new damage. And most relapses don't cause fever. So fever associated with symptom recurrence is usually not a sign of a new relapse. When you see us in the clinic and we do a neurologic examination, excuse me, if we find new evidence on your neurologic examination of some abnormality somewhere in the central nervous system that you've not previously experienced, that we didn't see previously on your examination, then that's also suggestive of new damage or dysfunction in the central nervous system. If we see new changes on the MRI that weren't there previously, then that's also very suggestive of excuse me, I'm getting over a cold. So if we see new changes on the MRI that weren't there previously, then we know there's been some new activity. And in particular, when we give gadolinium, the dye that we use with MRI, if those lesions or areas of abnormality light up with dye, that tells us that it's an area of active inflammation at the moment. And most MS lesions don't light up with dye for any more than about 6 weeks. They can be longer, but typical would be about 6 weeks. So that if we do an MRI and we see new lesions or enhancing lesions, then we know there has been some disease activity. So I want to spend a little time on talking about what do we do if you experience a multiple sclerosis relapse. So it depends a lot on what that relapse is and how severe it is. Like I mentioned before, most relapses improve, the symptoms improve over time. We've never really proven that the treatments that we give for relapses make people better in the long run. We believe they do. We treat relapses hoping that we make a long-term difference. But the best scientific evidence hasn't been able to demonstrate that. So I would say it's somewhat optional whether we treat relapses, depending on how severe they are, where they are in the central nervous system, how much they impair function, and how well the individual tolerates the treatments. So all of those things, we always want to weigh the risk versus the expected benefit. The typical treatment is to use very high dose of steroids, what we call corticosteroids. Those are different than the steroids that are banned with athletes' use and all. But we use very high doses, typically given intravenously, although they can be given orally. And what often happens is people's symptoms of the relapse improve dramatically and faster than they would if we didn't give the steroids. But again, we've never shown that the treatment of the relapse improves the patient's long-term outcome. There are other treatments that we can use as well. So ACTH stands for adrenocorticotropin hormone. It's the hormone, that's why we call it ACTH. It's a hormone that causes us to release cortisol, which is a steroid, from our adrenal glands. So giving ACTH is a way of administering our own steroids, if you will. We sometimes use intravenous immune globulin or plasmapheresis treatments, but most of those treatments other than steroids are treatments we would use when steroids are poorly tolerated or ineffective for treating the relapse. So all of those other alternatives are sort of second choices. The other thing I wanted to mention is, so what's the significance of a relapse? So the significance of a relapse is that there's inflammation going on in the brain and or spinal cord, and we therefore may or may not want to treat it. The other significance is, as I mentioned before, if you're having a relapse, it means we don't have the disease under complete control. So not only are we concerned about what we should do now to treat this relapse, but we're concerned about whether or not we need to change your long-term therapy. And to me, that's often a more crucial question than the treatment of the acute relapse. So I trust this information has been helpful as you try to understand the symptoms you experience or your family member experiences. And I'll keep adding other videos, hopefully that will be helpful in the future. Thanks.